or 3 months as we go through the winter period.
Paul Kerr, give us your analysis of what's going on, would you, Paul? Welcome.
Yeah, thank you, William. Like John, I'd like to emphasise, you will always get help if you come to an emergency department, but the problem is that you're waiting much longer than before. And we've known for a long time that things are getting worse. And we've been watching them get gradually worse and worse. And that's part of the problem. There's this problem of sort of normalisation where people are happy with 20 people waiting, and then they're happy with 30 people waiting, or 40 or 50 or 60 perhaps, as it is now. And there might be 300 people waiting. So you're kind of in this precarious position where you can't respond to an unexpected surge, or you can't respond to an proper emergency, what we would have called in the past a critical incident where maybe a bus crashes. And those patients are not going to get treated quite as well as they would have in a time-critical condition. And at the moment, for example, we might have 300 people literally queuing on trolleys to get a bed. And that situation has been getting worse progressively for some time. So we do need a plan. And however difficult that is, and I know there are all kinds of arguments around having extra beds, we have to have a plan to mitigate the problems that we are going to face this winter.
Danny Donnelly, some of the issues here in the Antrim Hospital most of them, as far as I can tell, have to do with care packages being unavailable, people who can be released medically, fine to release people, but you need to have a care package in place. There's now conversations about getting even partial care packages with the cooperation of families in order to create more spaces for people to come in. But in your experience, have you ever known of a hospital saying to people, don't come here in any circumstances, we can't help you?
No, I was very, very shocked to see that come up on my Twitter feed. And certainly as a nurse now, I've been working in hospitals where there have been extreme pressures, particularly over the winter months previously. And I feel for the staff that are working under those intense pressures for very, very long periods. It is incredibly stressful. And I know the staff just want to do everything they can to care for the patients, under their care. It is an incredibly stressful atmosphere and environment to work in. I understand that on Saturday night, the key factor was critically ill patients arriving in a very quick succession. Now the hospital management declared the emergency and put a plan in place. Yeah. And they started working to keep the patients safe within the hospital. So I'm very grateful, to all the staff in the hospital, in the A&E department, and to the managers for working so diligently to be able to mitigate that risk and to try and keep those patients as safe as possible. It doesn't take away from the fact that this was a very dangerous situation. There was a big area that did not have A&E coverage that night, and where people were being told to stay away from their A&E. In any circumstance, which, that is a very, very serious situation. Incredibly concerning. Now, we have heard from the Trust this morning, and, they talked about the reasons for this. One of the reasons, as you highlighted there, is lack of care packages within the community setting. I know the Trust are working to do as much as they can on that. And I would echo their request that families and patients work with the wards to try and do everything they can to get people who are medically fit. We do have people who are medically fit in hospital beds that can get discharged as soon as possible. So I would ask people just to work with the wards to try and get people discharged.
John, one of the criticisms that we hear from some about our health service, our health and social care service across the UK, whether it's the NHS and GB or our health system here, is we have a kind of almost mythic expectation for our healthcare system. But when you look at the outcomes across Europe, we do not have very good health outcomes. And when you look at health outcomes across the developed world, only America is worse than us, and they pay more.
Well, yes, I mean, I think there is something to be said.
So is there something fundamentally wrong about the way we fund and structure this system?
It's not so much about how we fund and structure the system. I think there is something about expectations from the system and what is reasonable and what is not reasonable. I mean, my line about all of this is, you have to deal with the things that happen on Saturday, Sunday as they're in your face, and you can't do other than deal with them when they're in your face. But essentially, managing and organising healthcare is always about establishing and understanding numbers. That can sometimes sound heartless, because when we all use the system, it's very personal to us and we don't like to be a number. But actually, if you want to talk about how you handle its numbers, how many ambulances come each day, because 50% of the people who come in ambulance will be admitted. How many people are discharged by noon in the day, because that materially affects your bed availability for later in the day. What is the total number of attendees per day, and what is the bed stock you should need? Now, I think clearly in the Antrim situation, it's a combination of two things. They have too few beds. I think that's been recognised for some considerable time, and I understand they're doing something about that at this juncture, getting 48 beds or that number in situ. And you can't magic that overnight. And you do have to do something about getting people sort of discharged from hospital. But I think the real issue here is about focus and direction. If you were to stand and ask people outside the building here, what are the 6 things the health service is trying to do right now? I think you might struggle to find out what the 6 things are. I mean, I think there are several things that are quite straightforward. I think sorting out what happens in our emergency departments is one, working on our waiting lists is the third, and improving our cancer treatment, our second, and improving cancer treatment is the third. We will do lots of other things, but we have to focus on 1 or 2 things. And if we don't do that, what we have is a very diffused focus on many things, with the result that not very much happens, and we find ourselves in these repeated and recurrent crises.
We Dog Walker on Twitter, that's what they're called, says, I'm sure you will not ask the DUP on to discuss the hospital closing its doors. We have asked the DUP to put someone on the programme. We're still waiting to hear back from them, but we certainly do want to hear from the DUP. We are joined by the Alliance MLA Danny Donnelly and Paul Kerr, the Vice President of the Royal College of Emergency Medicine here in Northern Ireland. Paul, a number of people texting me to say, look, is the issue here that people are continually going to emergency departments who don't need to go to emergency departments? Is that a big part of the problem?
No, William, that's a common misunderstanding. Unfortunately, that's not part of the problem. The activity has probably slowly declined in terms of emergency admissions in actual fact, but the number of people waiting to get a bed in the hospital, an emergency bed, has gradually increased. So that shows us that the bed availability, for whatever reason, has gradually declined. And the immediate reason is the fact that there's no access to those beds in the community for the medically fit patients. However, we've been in a precarious situation where that situation has been deteriorating for some years now. And then we were hit with COVID, which made that situation much worse. So we are gradually, not to be too unclear about it, we are in a dangerous situation where we risk patients not getting safe treatment. And indeed, the staff are not safe. And we are losing staff. And the whole system is propped up by staff. So if we don't have our staff, and if staff are leaving or perhaps coming back as agency staff, the costs are increasing. And then we can't do with that money what we should do in terms of increasing capacity in the system. So it's a very poor situation.
What about community hospitals, as they're sometimes called, or rehabilitation spaces?
I think at this moment we shouldn't be thinking of reducing capacity anywhere, but we should be working within the footprint of the system that we have at this time to increase the flow through the hospitals so that we get beds for those people in the community who are medically fit to be discharged. And we find ways of improving efficiency in the flow in the large hospitals so that we can get the emergency patients into the hospital and reduce the obstruction to the flow of ambulance patients, because there is, of course, a domino effect. And the domino effect even occurs in the situation where one hospital says it has to close its doors. The next hospital is going to get more patients and they're going to face a critical incident. So in Northern Ireland, it's a very small system, and we have to try to avoid this situation happening where one hospital closes its doors, because that is going to put us all at risk of being in the same situation.
It's pretty embarrassing for a developed world healthcare system that a hospital would be doing that, though embarrassment is not the issue. It's safety, patient safety is the principal issue. Jerry's in Derry. Hello, Jerry. Hi, Jerry.
How are you doing, William?
I'm doing very well.
I think the problem with the health service is not the way into the hospital, it's the way back out of it.
Yeah.
Because you go in through the accident and emergency, and I mean, that's up to his neck, and people, and they diagnose you and all the rest, and then try to get you bed in the hospital, and then you're on a bed in the hospital, medically capable of leaving that hospital if there's a care package at the end of it. And there's no care package at the end of it. There is where the problem lies.
Yeah.
We are not providing the care needed to get you out of hospital.
Jerry, thank you very much. You've put it very well. It's not, the problem is not getting into hospital, it's getting out again. That's a very interesting way of putting it. Jim is in Lisburn. Hello, Jim.
Oh, hi, William. Listening to this argument that's been going on for quite some time. And I just heard what the last gentleman said and echoed what we heard on the news this morning on Good Morning Ulster about beds, what they call bed blocking. But the other factor is, and I have a recent experience of it myself, is, GPs should be dealing with the minor issues in this world. And I had a recent incident where I was looking for an emergency script for some back pain. Not a big deal. And they said, there's no doctors here to do one for you. You may just go to A&E. And I said, look, I don't need to go in A&E. I don't need to bother these people with this. I just need somebody to do me a little script, and I'll go to the chemist and get the tablets. No, we can't do that for you. In the end, I ended up going to the pharmacist whom I had got them off before, and I said, can you check your records? He did. And he said, well, I can give you a very small amount here on the proviso that you bring me the script within a couple of days. And I said, well, that's fine, let's do that. But had I not been savvy enough to have known that,
interesting,
I'd have been tripping off to A&E and
Jim,
sitting blocking the place with another person who does not need to be there.
Thank you very much, Jim. Now, Paul, you said that sort of thing wasn't the reason for the problem. There are people getting in touch saying, I've had exactly the same experience. I can't get what I need through a pharmacy or a GP, and I go to A&E.
Yes, well, however frustrated they are about those encounters, they are not the cause of the emergency admission problem. Those patients come to hospital and they get whatever they need and they go home, and they don't end
You're not
up
going to be admitting those people, of course.
Lying on a trolley waiting. Yes. So when we break those two groups of patients down, we find one group gets treated in about 4 to 6 hours, and another group, the median admission time is about 14 to 18 hours. So they're a completely different group, and they're certainly not the cause. The minor problems are not the cause of this bed problem, this flow problem in the hospitals.
That's very helpful. Thank you very much. From the DUP.